Hi, this is QD Video brought to you by Room Now Live. Today's case is about when I would use Anakinra or an IL-1 inhibitor. So a 48-year-old woman comes in. She has long-standing, what I would call refractory RA. She's failed several TNF inhibitors, Actemra, tofacitinib, abatacept, and the question is, would you now consider, a combination of drugs, rituximab or Anakinra? Anakinra always seems to get left off the list. I'll remind you, it is a drug that is FDA approved for use in rheumatoid arthritis, where it was shown to be really effective in multiple trials that led to approval. But yet it falls off of everyone's list because everyone believes it doesn't really work. Well, that's not true. I've actually used it in rheumatoid arthritis with great success. I must say much less in recent years compared to when it was first developed back in 2002. So the question is, when would you or should you use an IL-1 inhibitor or Anakinra? There are 3 IL-1 inhibitors on the market. One is Anakinra, which is only approved for use in rheumatoid arthritis and NOMID. That's one of the 3 types of CAPS. Second is canakinumab, also known as Ilaris, that's approved for use in systemic JIA above the age of 2, CAPS, FMF, familial Mediterranean fever, hyper IgD syndrome, and TRAPS. Yes, it works in TRAPS, maybe better than using Enbrel. And lastly, there's rilonacept, also known as Arcalyst. It's only approved for CAPS. That's, again, the 3 periodic fever syndromes, Muckle-Wells syndrome, NOMID-SINCA, and familial cold autoinflammatory syndrome. Again, only one of these 3 TNF inhibitors is approved for use in patients with rheumatoid arthritis. So I think you should know the data about it. It is FDA approved. Again, you really can't compare FDA registration trials. And you might say that it actually had a lower ACR20 response rate compared to some of the other drugs. Not that much lower, and actually was similar to that seen with infliximab in the ATTRACT trial. But nonetheless, there are a number of different studies that have looked at the comparative efficacy of Anakinra in RA, and they all pretty much say the same thing. They say that it generally is less effective than other biologics, and when other biologics are looked at, especially in combination with methotrexate, they're all sort of equipotent. So there isn't good evidence that TNF inhibitors are better than IL-6 inhibitors or abatacept or rituximab or whatever. But there may be, again, network meta-analysis data that maybe it's a little bit lower with Anakinra, and that's why when you have 11 or 13 different choices as far as DMARD therapy, you don't have to use Anakinra, a daily injection. But it has also been studied in a randomized trial in early RA where it was not shown to be any more effective than taking methotrexate alone. So methotrexate alone versus methotrexate plus Anakinra, everybody got better, but the addition of Anakinra wasn't sufficient to advocate for it. That was a Cardera study from 2016. So again, who should get Anakinra in my clinic? Patients with or suspected as having Still's disease or systemic JIA. That's a no-brainer. That's the first-line therapy. You might want to use steroids while you're still working them up, but again, it's almost an empiric diagnostic trial, if you will, because they'll have a sort of gigantic prompt response. I think that undiagnosed suspected autoinflammatory disease, the use of Anakinra or other IL-1 inhibitors may be important. But here the issue is, do you use the daily Anakinra or the less frequently dosed Ilaris or canakinumab? Generally, my scheme has been to use daily Anakinra, get them under control, show that they have sustained efficacy, and then try to transition them to a drug that's taken less frequently, which is mainly going to be Ilaris, also known as canakinumab. What is the other indications? Well, I will use it in RA after patients have failed at least 2 or 3 other biologics. I will use it in people declared as being difficult refractory RA when I'm trying to investigate whether another mechanism is underlying the inflammatory arthritis. So if you've sort of failed the approach of inhibiting TNF, inhibiting IL-6, going after T cells, going after B cells, maybe going after IL-1 makes some sense. It may also be a drug worth using in patients whom you cannot use other biologics or TNF inhibitors. For instance, patients with hepatitis B, especially acute infections, or even those who have recovered from hepatitis B and you're worried about it. Patients who've had past fungal infections that have been a deep tissue fungal infection for which biologics and TNF inhibitors may be contraindicated. Same for TB, and also for patients who are on intravesicular BCG. They can't receive TNF inhibitors. They certainly could receive other MOA biologics, including anakinra. I generally do not use them in where it's been written about, but not FDA approved. That's where it's been shown to be effective in acute gout, in acute pseudo gout due to CPPD crystal deposition disease, and in type 2 diabetes. Although there's evidence out there for their efficacy, I just haven't needed to use that in any management of any of my patients. So that's it for QD video. Check out roomnow.live. It's a meeting for curious, mind-bending rheumatologists who want to be in the know and who want to be good teachers. Check out roomnow.live and register.